That's right.
I can't think.
Yeah.
The screen's too small.
Beers.
Okay, we got to hurry up and do this while my laptop is temporarily working, apparently. I'm Gina Whitney. I'm the Vice Chair of QI for the department. I am primarily over at Children's, and I hide from you guys on the third floor usually. I occasionally get to come down to the general OR and do a case. So in general, I don't meet a lot of the residents, which is unfortunate. But occasionally I get to do one of the peds cardiac cases with you guys in the general OR. So I may meet you there. So I'm going to talk a little bit about QI generally, and then I really wanted to leave time to talk about projects, potential projects, what things are really doable and really helpful to the department so that it persists and leaves a legacy long after you are long gone, forgotten about us, and we're still slaving away. And you guys have really awesome jobs. So one of the nice things about anesthesiologists, I think more so than any other type of physician in the hospital, is that they tend to see systems and they see them very clearly and they impact your day-to-day life, right? I mean, think of how many times you show up to an OR and the surgeon has been doing surgery for 30 years and they have no idea what has to happen in that room before they show up and just operate, right? You guys are so inextricably intertwined with the processes in the hospital that you tend to see them. And so it's kind of a double-sided coin, right? Because you think everything in this hospital is broken, nothing works. And then the other thing you see is you want to work on stuff and improve it, and you're very well positioned to do that. Not only doing QI projects, but later as you get into attending hood and taking on leadership roles in the hospital, you're a very helpful voice because you balance the physician side, you know the nursing issues that come up and the process issues that tend to come up with other departments. So in general, you guys are well positioned to do this kind of work in any role. So I wanted to talk a little bit about choosing what to work on. Allison was forcing you guys to make a choice just now, but
well, for the last 3 months.
It's not too late. You can. She's been barraging you with emails. I think the most helpful projects, we've got things that we're sort of prioritizing as a department that we see as deficiencies that need to be addressed. So things that have sort of departmental buy-in from leadership and we know need to be worked on are super helpful. So like that OB timeout. A very limited in scope, succinct project, definable, small team to work on it. Perfect. So, and that's the one where you can really make a difference. That'll, long after you've got some awesome chronic pain job somewhere, we will still be using your checklist. I won't be, but some other poor unfortunate soul doing OB anesthesia will be. So anyway, in general, if you have, we don't work in silos very often at all. So if you have other disciplines that are going to be involved in your process, RTs, nurses, techs, it adds complexity, but it also, I think, adds impact. There's very few things that we sort of do in isolation. So that's something to keep in mind. In general, if you have sort of a small cohort of specialized people, that tends to be the most effective team because you get to know each other and trust each other. They know who you are. You're no longer named anesthesia, right? So if you are working within spine or burn, like some sort of small subset of people, the work tends to go a little bit faster and be a little bit easier to move things forward. So, and we used to, not so much anymore, talk about burning platforms and this idea that you had to scare the hell out of people to make them want to work on anything. And every project had a burning platform and you'd have some crazy case and that was the burning platform. And then we all got really tired of burning platforms. So we try not to have burning platforms. This is a process that, the care improves over time. And I can say as somebody who's had a family member had major surgery here, what the kinks in the system that you guys see, it really actually works pretty well from the other side, believe it or not. And you don't see it until you're a patient or a family member. You'd be shocked at how well most things go here. So the whole point of QI, where do you see yourself in 5 years? If you are sitting in a cubicle talking to the same person about the same problem, right, that's not a very rewarding thing to do. So that's kind of what first got me interested in quality improvement. I was a peds cardiac anesthesiologist somewhere. We had quite a bit of problem with bleeding, like bleeding to death, bleeding after cardiac surgery in small infants, and it was a struggle. We didn't have our own blood bank, and the total volume in these babies is like 240, 260 mLs. That's their entire blood volume. So a little hole in the aorta can be problematic, as you might imagine. So we started tackling some of those issues, and really the first major project I worked on was looking at standardizing our transfusion practices. And I went at it as, I think it's a proline deficiency, but if anesthesiology is contributing, I want to know that we're doing the best job that we can possibly do to resuscitate these patients. Plus, I had a team of 6 anesthesiologists that all wanted to work on the problem. So I thought, if we're going to go at this in good faith, we got to fix the anesthesia side first, and we got to be able to describe clearly and coherently and based on the evidence what our practice is. So that's what I did. So this is some of the just the graphics that were kind of all over the hospital. That eventually there was an ICU version that became a mouse pad. So no matter where you were, you knew what the transfusion process was. You had no excuse because you were entering the order in the computer. So one thing that often comes up and is not necessarily as straightforward of a question as you would think is the difference between quality improvement and research. And so I generally, the high level way to think about it is research, you're asking a question that you don't know the answer to, and in quality improvement research, you have a goal. And if you can frame your question that way, then that is helpful. There are some projects that very much ride that line. And if you reorganize it a little bit and change the way you're looking at the information, then it can become, you can turn it into a QI project. There's enough of an evidence base there that you're not, totally going rogue. We had, for example, Alan Bielski wanted to look at erector spinae blocks in patients that undergo the Nuss procedure, the bar placement. And he had it framed in such a way that it really was a research project, but his intention was QI to decrease length of stay. So how do we decrease length of stay in patients following Nuss procedure? What are the limiting factors? So just by reframing the question, we were able to tweak it quite a bit and make it a much more sort of interesting, doable, faster paced project than, randomizing patients between epidural and erector spinae block, that kind of thing. I've literally told you all I remember about regional just then. So research generates new knowledge. It describes the current state. You'll look a lot at before and after kind of data to try and describe the situation. And you use statistical tools that you guys have all learned in prior statistics courses, and you may or may not remember. And then obviously you go through the IRB. Quality improvement, I mentioned. You frame the project as a goal. What do you want to work on? You're relying largely on existing evidence-based or like general common sense. And you can't be too loose with that definition. A lot of people try and be really loose with the common sense part. Well, of course it's common sense that works better. Well, no, it's actually not. So go back. And the thing that I think in my mind helps me distinguish is an extension of the operational processes of the hospital. So, for example, what we were just talking about, blood bank. So when you transfuse blood, it turns out you're not supposed to transfuse blood with lactated ringers. I learned that like 3 years ago. I've been giving blood for a long time. So what about the hospital process? Can we change to make it more likely that somebody's going to transfuse with the right fluid that doesn't violate FDA rules? So, how do you make sure normal saline is always there, that people remember? Do you deliver it with blood? So how do you change processes to sort of tweak the way people make decisions? So without having to nag the crap out of them with daily emails about what they did wrong, or department-wide things like after you give Versed, don't walk away, those kind of things, little reminders. Those are, how do you change what's called decision architecture so that people are more likely to make the right decision without even thinking about it, to make the default thing the right thing to do. And quality improvement looks at the data over time. You guys have all seen run charts, I'm sure. That's the simplest way to show data. And then the idea, and I talked earlier about limiting scope, and this is certainly an issue for your projects that you do as residents, but using a local, very local process, changing it, learning from it, fixing the problem and then adapting it for other areas so that you're not imposing from above. I think we can be pretty heavy-handed sometimes, so around issues of sedation that other specialties deal with pretty often, where we sort of have really more expertise, sedation, airway management, that kind of thing. So how do you adapt things locally so that it's better received and you're more likely to end up with a partnership with that group of people rather than us sort of lording over them and monitoring them. And then approval pathways vary by institution. Here, there's no IRB approval. There's not a separate QI thing. It's sort of there's not really a process in place. At Children's, there's a committee called ORCORP, and then before something goes through, if you guys do a QI project, you submit it through the research portal. Okay, it's a little concerning. You submit it through the research portal. So I could get it through Evernote.
Onto here?
Onto that, yeah. Hang on, let me. Is there a keyboard? Okay. Oh, I may not be able to log on. Yeah. So weird.
I don't know why.
I wonder if my power cord's gone bad or something.
Wow, it's like the extent of my IT knowledge.
Oh, I wasn't expecting it either.
Classic dense.
Do any of you guys use Evernote? I am addicted to it. It has organized my life.
It was super cool.
Oh, you ended up doing that. What'd you use? Tell me. Eliminate line.
To go? It's going.
Yeah. Like that they have a standard card back, and sometimes he's right here, he would paste it, and then they would draw, and
I did up there. Isn't there events?
That way we you can at least say say ask her later.
Did that the first time.
Now accept. This is
Okay. Got it? I'm scared to try it. Okay. Okay, so there's several different kinds of ways to look at QI. This model from improvement is the IHI sort of way of thinking about problems. It's all very simple. What's the goal? What are we trying to do? How do we know that our change is an improvement? What are we going to measure? And what are we going to try to get there? It's very simple. This is not rocket science. You'll hear people talk about PDSA cycles, which is an individual intervention and looking at how it changed things or didn't, deciding what you learned from it. So that's the study part. That part often gets skipped, but it's important. And a series of PDSA cycles is a PDSA ramp. So you'll hear these phrases. It's all very intuitive, so the fact that they sort of name these things is a little bit silly. There's also certain changes that you know are going to solve a problem that you just need to fix. So you don't need to do a 12-month QI project to decide to put the lime dressing where the nurse can get to them easily. You just fix it. So anyway, I call that a Nike implementation. So hatching a QI project, you really want to come up with a goal. And And you also want to have a good understanding of the evidence base behind the question that you're asking. So we get some projects where, just a basic literature search would have helped steer you towards an actual doable project, but you're asking a question that's already been answered. So that's something to be sort of cognizant of. You should be, when you're an anesthesiologist doing QI, what you add that the PI, the process improvement people and the clinical quality specialists don't know is the clinical information. You are the content expert, and that is what you bring to the table. So when you have QI skills and the content expertise, like, you're golden, you're awesome. So you're super helpful to the process, because there's a lot of people perfectly willing to change the process of your work, daily work, that have no idea what you do, as I'm sure you are already aware. And then baseline data, it's funny because I'll get collecting baseline data. I think the default is, especially now in the age of Epic and EMR, you think I'm gonna get data from 5,000 people, and we're going to look historically, when really what you need to do is go through 50 charts. And that will save you a year of your life and a lot of gray hair. So if you structure the project correctly, you can do very small cohorts, look at what happened, look at outliers, both positive and negative, and make changes, learn from those and make changes based on those. You think, we're all living in this age. We thought we were going to be living in this age of big data, and that is very elusive. And you can speak to that, right, with your trauma data, how hard it is to get a data set and to go through the data issues. It is, the way data is mapped, it is incredibly complex, particularly within Epic, because it's a database that is designed unlike any other, because the originator of Epic was friends with some weird non-hierarchical database person. So you can't find people that know enough about Epic to help you a lot of times. It's like a national problem. So is anybody an IT person here? Did I say that all correctly? Okay, good. No one's going to call me out on it? Okay. It's really hard. And like with Brooke's data, she had a big data set that she wanted to get about trauma. And so we had to sit down and then go through manually by hand, find the data point she was looking for, and then show it to the data analyst so he can get a code. I mean, that's how difficult and time-consuming it is. And then we would get a data set back and look at it, and it was like half wrong, and then we're going back to the drawing board, like over and over and over again. And this process went quickly. So just to give you an idea, you're better off picking a process where you can do a small cohort, like patients that have spines done. The answer to but the answer, if spinal fusion, if you want to look at big complex spines and their outcomes, the answer is to go just get it out of the chart from a realistic standpoint, unless you're going to make it a 20-year project. The other thing is to have an understanding of the existing process that exists, and there's something called process mapping, and then what's called failure modes and effects analysis. And that basically is drawing little boxes with arrows and then noting, it's a fancy way of saying where everything goes wrong and where it can be expected to go wrong based on your experience and knowledge. So identifying stakeholders and using them as a resource. A lot of times these people have known that something doesn't work for a long time, and they're really glad to finally be heard. And then developing relationships with the people that you work with. Like I said, smaller groups are a lot easier to move the needle really quickly. So detractors can be a great resource. You got to learn who to engage and who to ignore. If you repeat the ignore part, I'll deny that I said it. But there are people that are very vocal and very cynical. Those people are the best. They have usually thought critically about it and have given up. So what I'll do is I'll usually engage those people separately, not in public, because otherwise your project will be DOA. I'll engage those people separately. They have seen everything I'm presenting before the meeting, had a chance to give me their honest, unfiltered, cynical feedback, Larry Schwartz, okay? And I've made improvements based on that, and then I've got that person on board. So there's a cohort of people that have seen everything I've done before I present it publicly. And I just told you one of their names. But anyway, so like when we did not have a drug, you guys all know this, we did not have a drug library up until about a month ago. We went back and forth on the drug library for months, getting it just perfect. And the way we got them on board, they were going, hey, you do a drug library, I'm leaving, blah, 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 And but they had seen every step of it and had input at every step, or at least thought, they had been heard. I didn't listen to everything that they had to say, but anyway, they're very helpful. And so you got to know how to kind of use those people for what they have to offer, but still manage them, I guess, is the best way to say it. So APSF has done a lot of work looking at, this was a survey from like 15 years ago now. So looking at most common patient safety threats within the perioperative environment. Airway is number 1, and production pressure is number 2, which I think production pressure is 1, 2, and 3 personally. Reading reports, it's always we were in a hurry, and then anesthesia at remote sites obviously is increasingly challenging with sicker and sicker patients and more productivity pressure demands. But anyway, so these are what is ranked as the biggest patient safety priorities. It was 800 respondents, like 60% of them were private practice. So just to give you an idea, I don't know that it's changed all that much, but other than perhaps the production pressure is more than it was 20 years ago, I don't think any of us have been doing it that long. But and this is 11 through 20, just to give you an idea. Obesity may have moved up, but and then I think work hours is up there, but that's just me. So APSF has released a series of 12 priorities, things that they want to target that they think we can impact and improve patient care. If you have an opportunity to go to the APSF national meeting, it is a great meeting. It's unfortunately, it was in Phoenix in September, so it was literally like 100 was the low for the day. I did not leave the hotel for 3 days. But it's a working meeting. So they pick one topic, they invite industry, they invite thought leaders, they invite a very multidisciplinary group of people, nursing leadership, and they solve a problem. And so this actually, number 1 here was preventing and detecting clinical deterioration in peri-op patients was the topic of the topic this year. And so we did sort of have you guys ever heard of IDEO? It's out in Silicon Valley or thereabouts, and it's sort of an early prototyping thought center where they bring in kind of crazy creative people and try and solve problems in new and different ways. And one of the things they talk about is early prototyping. I should have brought pictures of some of our prototypes. They're awful. We were literally working with pipe cleaners. But designing systems and processes and products that we think can help solve this problem. And it was an interesting way to look at a problem and work on it in a multidisciplinary way. It was really just kind of fun and interesting. It was very different from your usual sort of passive meeting, try and find the conference room. There were only like 200 people there. But they had people from aviation industry, just craziness. So the cool thing is that they put together these after groups that we all voted, and sort of there was like a fantasy football version for like the best prototype. And so now we have people from industry engaging, and we're all, working on this remotely to try and get prototypes of products up and running. So it was really a fun meeting. It was unlike anything I've ever been to, but I really enjoyed it. Safety and out of OR locations, culture of safety, medication safety. You know what culture of safety is? The best way to describe it is what you do when no one's looking. You scrub in the hub, that kind of thing. So what you do when no one's looking, medication safety for obvious reasons. You guys have seen, I'm sure, I think I sent out that paper actually about medication errors in anesthesia where they had a direct observer. And it's like 40% of cases there's a medication error. Not all of them reach the patient, but it's pretty alarming. Most of them we are able to correct, so I think we get away with them a little bit more. Perioperative delirium and cognitive dysfunction. If somebody had a longer term commitment and was interested in staying or wanted to do a longer project, I think cognitive dysfunction in the elderly undergoing surgery would be a huge, great QI project. I think probably most people would agree that most of these patients are probably over anesthetized. And how do we optimize their anesthetic to achieve various outcomes? And I think there's probably enough data out there to make them process measures rather than outcome measures, so it'll be easier to detect a change. So. Hospital-acquired infection and environmental contamination. Do you guys all get the APSF newsletter? It's the green and white, and it's usually a great sort of succinct but pretty thorough summary of an issue. That was the most recent. Communication issues, as you know, this is like in 70% of patient safety events. This is one of the issues. Every year, somebody seems to do a handoff transition of care project. And I think, honestly, it's very helpful because I think there are a lot of really dangerous transitions that happen, and we see all the time things get missed because of the same deficit in that handoff. And then airway management difficulties, skills, and equipment, which actually, if you guys know Tyler Morsey, you would have overlapped with him, right? So he would have been a third year when you were first year. So anyway, so he's our senior fellow in QI at Children's, and that is what he's working on, is organizational approaches to management of difficult airway. And so I think, he can make a career out of that because nobody's really done that work, particularly in children. In children, it's very less common to have anesthesia come and intubate. The pediatricians will try. And so it can end up in a free-for-all pretty quickly. Those kids do not take a joke, as you all are aware. Integration of safety into process improvement. So like I said, you guys are content experts, so the more that you can engage those folks and kind of get them in the right direction. And then patient safety priorities, burnout, which is a huge issue, and then distractions while doing anesthetics. I didn't know how to number from 7 to 12 on a different slide, so I called it part 2. There you go. I was like, why is that 1 through 6? So when you are doing a project, this guy was sort of a thinker about how you solve problems. And I've always said his name Donabedian, but I think that it's actually said differently. But so he talks about structure, process, and outcome. And structure is what do you have available within that system, right? So do you have an M&M? Do you have a place to review cases? For Sam Gillen's glucose project, do you have point of care testing at admission? Structural sort of things that are prerequisites to doing that type of work. Process measures are such things as, did you give, for the PONV risk for that patient, did you give the right antiemetics during the case? And outcome measures are, obviously, clearly the outcome. The outcome measures can be very hard to move, so that depending on the strength of the data, you may use process outcomes as your primary. If you know they're closely correlated with the outcome, you might use process measures as your actual outcome in a project. The modification that I usually add in is I will add balancing measures, and that is the information you can get from those cynics I told you about. The things that they are worried about affecting either downstream or within. So in the glucose management project, we want to be able to detect hypoglycemia and know about it. So for example, that was a balancing measure in that project. So this is Sam's project. I just put together this sketch just to give you an idea, but we've kind of gone through most of that. Process, is there a very clear insulin management protocol available to people? Do they know who to contact? We had talked about getting the glucose management team involved, but we delayed that for later. Do we have enough insulin? Do we have enough testing strips, that kind of thing? And then balancing measures were incidence of hypoglycemia, and then any adverse event related to glucose testing. So having to place a second IV and having an IV infiltrate or whatever. So multidisciplinary team. The hardest part being a physician is the project management aspect, because you have a week where you work a reasonable amount of hours, and then you have a week where you work 70 hours and you get killed and there's like no food in your fridge and you've got 700 emails waiting on you. It's hard to keep a project moving when your workload kind of goes way up and down like that. So project management can be huge for a larger project. Gabby Inglesby, who I think you guys have all met at some point. Do you know her?
You will eventually.
She's our quality nurse, and she is like awesome because she's had every other job in the OR. Like she's been a circulator, she's been an educator, she has all the jobs. So she really knows the OR well. So she's great at helping us sort of stay on task and keep us honest. And also to give us the sort of the nursing perspective, which I think it can be easy to forget. And then executive team sponsorship is huge. If you pick a project that is in line with the goals of the organization, you'll get support. So the blood transfusion project that I did, for example, I didn't get any help at first, and it was me coming up with, looking at hundreds and hundreds of data sets from blood bank and manually entering how much each patient was transfused and on what date and time. And I'm not even kidding you, it was thousands of lines long. once I had that basic data set and we saw what we were able to do just by having an actual transfusion algorithm and plan within the OR, we saw 30% reductions in transfusion. And so once we were able to demonstrate that with a little bit of front-loaded work, then I got a data analyst, then I got a person to help me, then I got somebody to do my data viz stuff. So then it started to get resourced centrally once they realized they were saving money. We ended up extending that kind of a approach to transfusion across the institution, and we were saving like $22 million every year, just once we finally got things up and running, and really by inserting decision support to make evidence-based transfusion practices. What we found is we could look at the time during the day when transfusions were given. Any guess as to when it's most common? Not in a trauma?
Middle of the night.
Right before rounds, when they see the labs and they want to fix the numbers before rounds. So we stopped some of that. And then, like I said, here we don't have an active human factors engineer involved, but to me, somebody with a background in industrial engineering or human factors engineer, very helpful for seeing processes in a very different way. You're the content expert. And then the hardest part of this, honestly, is change management. And that's one of those things that limiting the size of your team is very helpful, because that'll be much less of a challenge. It is really hard. It's like herding cats. And I think one of the challenges is the way you lead and talk to other physicians. You know, nobody likes to be bossed around, especially by email. And so basically changing the way, the environment in which people make decisions, giving them better information goes a long way, just sort of respecting people's autonomy and hearing what they have to say. So choosing metrics, this is an important component of things, depending on how you want it to go. You'll get involved at some point in, Melanie might start nodding, but you'll get involved in sort of hospital level QI projects where there's a failure to determine a goal, and you just flop around and go to meetings for like years. Would you agree to that? And it's so frustrating because you're not in charge of it, and you're getting kind of thrown around in the wind. But anyway, the way to keep a project on track is to have metrics that are well designed, they are clear, and they are going to move if you impact the process. And so it allows people to be sort of pointed in the same direction and on the same team. It lets you know if you've been successful. So designing a project, I talk about the different types of data, so structural, process, outcome, and balancing measures. Run chart is probably the simplest way that people will collect data and display it. The nice thing is people will annotate it, so you'll actually have comments about when different interventions happen, and you can see the effect, and it's all very commonsensical. And it's easy to communicate to people. Some people over to the right will put an arrow up is good or something, so that people know if you're trying to raise something or lower something, so they can come away with a quick overall impression of what's going on. So the cooler part, I won't go too much into depth on this, but QI has there's a lot more technical aspects that you can really learn a lot about a process. Is anybody here have an engineering background? What? There's always engineers
with engineer. There's here.
But anyway, it comes from manufacturing. So this guy Deming talks about processes and measuring processes, and then Schuhart was the one that sort of also worked in manufacturing in the car industry. It's really a very powerful way to look at data to tell more of a story. So it helps you to understand variability in the data. So you guys have all heard of Six Sigma, right? So that is a means of talking about variability in the data. So you can see I'm afraid I'm going to turn it off. Okay, that is a pointer, but it doesn't work. So anyway, so when you talk about variation in the data, so Six Sigma is 3 up and 3 down, and that's 99.7% of all data points. You can look at variability in the data and just determine if it's random variation, so common cause variation, or what's called special cause variation, and that is something that's weird and that you should look into, so you don't waste your time looking at natural variability, right? If I say the turnover for this room is 29, 32, 28, 30 minutes, you're going to say, well, that doesn't mean anything, right? But if I tell you it's 28, 72, 40, if it's all over the place, you in your mind know, well, something must have been wonky with that second case. This is a mathematical way to do that same thing, okay? There are upper and lower control limits, which are defined by the sample size and the variability of the data set. When you get into really large data sets, one of the problems is that any variability at all looks significant because the averages and the medians are so tight. So any outlier looks like special cause, and it's not. You have to use a special kind of control chart. That's like blurry, sorry. Okay, so anatomy of a control chart. I've kind of gone through this. That center line describes the process before the intervention. And there's an upper control limit based, again, on sample size and variability, and a lower control limit. So this will tell you 6 sigma of where that process is going to vary. And then once you make a process change, you change your center line, and then your control limits will also change. So this process actually became much more stable. See how it kind of settled out right there? But there's just kind of cool things you can look at in a process. And you know it intuitively, but this is just the mathematical, graphical way of looking at that. So there's actually a statistician. He's like the only interesting statistician you will ever meet. It's this guy, Lloyd Provost. And if you can find a review article by him, he's like fascinating because he actually has done the math that takes traditional statistics and flips it into control charts which to me is much more intuitive and meaningful and helpful. So what you want to know is if something is just random variation, right? So common cause variation, which you know it when you see it usually. There are rules for what constitutes special cause variation, so 4, 5, or 6 in a row, depending on the rule. So this downward trend, that cluster would be special cause variation, and that is where you want to look to see what was going on. So you're not wasting your time examining every point. You're defining what is special cause variation, and you're going back and looking at that. And this is why I said you can look at small data sets. So this lends itself more so to small data sets. You don't need the 1,000 line Excel spreadsheet to know about variability in data. There's all kinds of different Shoe-Hart charts depending on the type of data, whether it's classification or continuous data. The continuous data sets tend to be very much more powerful, but you can do classification data. So proportions, there's a P chart. Count data is, like days between adverse outcomes or cases between adverse outcomes if there's a lot of seasonal variation. So there's different ways to look at this data, and just know that it's powerful, and it will steer you where to look till you find where you find special cause that you need to look at. So anything above the upper control limit, that's going to be special cause variation. That's going to be something you're going to go look at and figure out. And that may tell you something about the process that will drive your next intervention. And then an unstable trend here, that's special cause variation as well. That'd be another place you'd go back and look. Something happened there. And these are all statistically based, and Lloyd Provost is the guy that kind of defined most of this. So process capability is kind of cool. It's not it's blurrier on mine, but the way to think about this is once you have data on a process, if you want to know if the same process would be able to achieve something, once a process is stable, there's no special cause variation within the process, you can look at the capability or the capacity of the process. So if I told you, and you know this intuitively already. So if I told you, okay, we're going to do 5-minute turnovers from now on. Okay, we're going to do that. It's going to be awesome. It's going to be great. You guys are going to love it. Everybody in this room knows there is no way in hell that is going to happen. That this system does not do that. Okay, so that's the intuitive way of thinking about this. But based on measurements and based on the variability, you can look at the capacity or the capability of a process and know what you should be able to achieve with that existing process in place. And if you can't get there, then you need to change the process. So there are mathematical ways of looking at it, I guess is my point. So major pitfalls in doing QI, scope. I've had issues trying to identify all the stakeholders. You want to overreach and reach out to people. Failure to learn from failed PDSA cycles. You go in thinking you know the answer, and so if something doesn't work, it doesn't fit what you already thought or your mental model, you drop it, you don't think about it. You will occasionally piss somebody off by changing it. There's a lot of people very invested in not changing their job or their responsibility or the way they've always done things. And that can be hard, and I think sometimes is the hardest part of managing this, and can be very frustrating, honestly. But there are early adopters who have noticed a problem and want to change it, and you've got to identify those people. And then, like I said, learn from it, but don't dwell. They'll get over it. And then communication plan. I think one of the hard things is when there's so many different projects going on all the time, like you just get bombarded, right? And at a certain point, you're like, okay, I know about these two, but these other 7 projects that are going on, just tell me what you want me to do and I'll do it, right? Like we're all pretty good sports. I know you got a project going on. I know this needs to be changed. Just tell me what you do and I'll do it. And so I often will try and have people publish project summaries. So like it's available on the website that you could just pull it up and see kind of vaguely what people are looking at and what we're asking you to do. And then have a means of disseminating your work. Shoe heart charts, you don't tend to disseminate because people don't really understand them unless they do this all the time. But run charts are very easy to communicate. People like seeing data. They want to know that, they're not just checking the glucose on every patient when they come in, because that's a lot of work, right? We're asking people to do a lot of work. Well, it turns out our compliance now with tight glycemic control is like 80%. And so how do we communicate that best to the people that are really kind of inconvenienced by some of this work? But let's see, I think I told you all this. One thing that I will say, so the executive team has to be pretty high functioning in order to do this. There's a lot of people that would rather just move faster and do the same thing faster. I think there has to be sort of a certain mindset towards safety in some of these operational decisions. And these are a lot of conversations that I end in fairly frequently. If you were interested in doing this kind of work as a physician, quite honestly, physicians will often come to these meetings and they're very passive participants. If you show up and you engage and you follow through it and you do the work you said you were going to do, you are like top 1%. I'm not even making that up. I might be underestimating. And then understanding how various personalities respond to change. Generally, depending on the change, people will be pretty easygoing, but there are definitely sort of cohorts of early adopters, and then there's some people you'll never move. And then establishing network of collaborators and identifying stakeholders. So, okay, so this is the last 2 books on there, the Improvement Guide and the Healthcare Data Guide. Those are like basic books about QI that I think are really good. Lloyd Provost is on both of those, and Sandy Murray is also on both of those. The book Nudge is really, I think, a great read if you haven't already read it. And it talks about how people make decisions. And once you understand how people make decisions, then it's a little bit easier to guide defaults within a system without having to strong arm people, without having to clutter their brains with what you want them to do. You guys have heard of the SALT trial at Vanderbilt. That came from where I was previous. They literally changed the default fluid in the OR and then had, for like a year, and then had a randomized trial, right, between LR and NS. And that work would never have been able, think of the ramifications of trying to do that work. They just changed the default box that was clicked in the order set for the OR. So that was it. And I think that was in New England Journal, actually. And then I know you guys are all struggling to return your emails. So this is like my general well-being book that I'm going to point you guys to. But this is a great book about kind of how to stay on top of things and projects and make sure you're moving them forward and keep you from drowning in email. Like I see people with like 2,300 unopened emails in their phone, and I'm like, I'd have to take a month off work. I wouldn't be able to function. Laughing, but I seriously, I couldn't do that. So, how do you sort of best regulate what you're working on and make sure that it's the important stuff? So really interested in this stuff, come and find me. I'm always happy to sit down and talk through a project. I may not know the content stuff, but I'm relying on you for that. We currently have a senior fellow in QI at Children's. It is Tyler, and he is working, like I said, on difficult airway response at Children's. And we are working to bring the senior fellowship in QI to UCH as well, and it would be one of those hybrid positions, same as neuro or anything else, where you can get a little bit more into this stuff. And at least with Tyler's, we got him approved. So he's spending 4 weeks in Salt Lake City at Intermountain Health, which is one of the top places. It's a different place than where I did my training, so that's great actually, because we got kind of get both perspectives. And he's having a great time and he loves it. He seems a little bit stressed out about getting baseline data, but it's all part of it. So anyway, but that's it.
So I have all of the projects that we suggested.
Mm-hmm.
Do you want me to pull those up and then do you have time to hang around for another 30 minutes or so? There are like 3 people in this room that have not signed up for things.
She's gonna come find you guys.
Come find you. I did.
Nathaniel was just talking about, so.
You good?
Yeah.
Camera on the classroom.
Uh-huh. Supposedly the people at Lake Denver Health are watching. They're not watching.
I know, I have etc.
Does anybody need to sign in before I take this thing?
But then he left.
Dan made her webpage.
Just really good jump.
She's doing family shit.
You have to remember what these little short phrases mean.
Right.
I cannot get a green button this time.
It's bigger. It was bigger a second ago.
There should be a spot on the bottom. To the right, there's a slide bar. Oh, the other thing I was going to tell you guys that if you are still looking for project ideas, like, no, never mind. Learning to use Excel and having more than basic proficiency in Excel is like life-changing if you're going into academics.
Excel classes like through.
So
Through the library.
Yeah, I don't know how to use Excel. We don't know.
So lynda.com, I think I told you about it. That's how I learned it. Called out, but it's LYNDA, lynda.com. And so that's like an online training platform for like all kinds of software, like 3D printing, like everything. But their Excel training is great. And it's in little like 10 to 15 minute modules. So if I want to go and look up a specific thing I'm trying to do, I can just go to the 10-minute module and learn it. So I went through the basic and the intermediate, like just in sequence, and then now I just go back to problem solve. So if you're trying to do something complex.
We'll put that on the Canvas thing.
Yeah, super helpful. And I want to say there's a CU subscription.
So we'll show them that soon, but we have a whole Canvas module that you guys are going to have access to and be expected to turn in your projects that way. So we'll put that link and hopefully the directions on how to get into it if we actually have a department way.
Okay.
We'll see.
We'll get a department.
Okay. I like it.
Josh, you've also too.
So the majority of you guys, thank you very much at this point, have signed up. Some of you are today. There are still, 6 or 7 of you out of 45 plus that need a project. So we won't go over too much what all these are. But I do want to show you where the holes are and see if you want to switch. So blood bank, there's a blood bank project at UCH. The majority of these projects are going to be university-based. We have Tyler kind of spearheading the one he volunteered, or 1 or 2 he volunteered for. And then we can go from there. But blood banking at UCH, that was a project that'll be ongoing from last year. We have quite a few representatives. If you guys want to give a little spiel, if you want some more CA1s on your team.
Enthusiastic, hardworking.
Uh-huh.
So basically, we're looking at like blood banking process and trying to minimize blood product wastage by basically looking at the amount of time that blood products are assigned to a given patient and trying to minimize that in our elective surgery patients.
Because when you order blood,
Yeah.
it stays connected to that patient for what, 3 or 5 days or something like that. 3. And then it can't be used for other people, even if they went home. Okay. So blood bank at UCH has some holes for CA1s, not so much for CA2s. Aspirin continuation. Nate, I thought I saw you here.
This was originally Tom's baby, so he came up with the idea.
Sounds like a disclaimer to me.
He does have Tom has asterisks by his name.
Yeah, he has asterisks.
Yeah.
In general.
Yeah, he's clearly the boss. It was originally his pet project. We're going to look at, starting with the orthopedic surgery clinic, we're going to create a kind of a guideline for continuing perioperative aspirin and go into the clinic and provide education to the NPs and those people in the surgery clinic that are instructing patients to hold medications to not hold this medication, and then follow those across, ideally across the course of a year, most likely be about 8 or 9 months of data of tracking the compliance rate of continuing perioperative aspirin.
So I will tell you, Melanie's already heard the story. So when my dad had a DBS put in here, so he was here like 3 different times. Pre-procedure and the clinic, we literally had like 4 sets of instructions that were all different about what to do with medications on the morning of surgery. My very well-educated parents were so freaking confused. I was like, "Don't you worry, I got you." Like, I'll tell you what to take in the morning. They just couldn't. So many people were giving them bad information. Some of it was important, like Rotari. That's kind of an essential. But anyway, it was really noticeable. That process is totally disconnected from.
So your problem statement's easy, and then figuring out the whys and the hows. So you guys have some room maybe for CA2 or 2, but that one's got some enthusiasm there. PACU workflow. Raleigh is not here, and neither is Glenn. Right? No. And so from what was that? Oh, he's right here. Okay. And Raleigh's husband got in a car accident, so she sent me a text too. He's fine though. They are looking at the lack of kind of resident follow through for PACU workflow. So seeing that you guys don't really know, like once you drop the patient off in PACU, it becomes a black box of what happened to my patient other than can I look at the flow sheet? And they want to improve that process and see if I think part of what they wanted to look at was, does it improve your engagement? Does it change your care? Does it change your satisfaction with your job? All those kind of things. So there is room for people to join that team as well.
All right. I don't have interest in the group, but I do have a suggestion. If you want to pass it along to them. So Children's has this thing on Epic called The Guardian, where you can actually see your patient and every patient of the day through their hospital stay. So they might want to look into getting that into Epic. But
I'm going to send them your way to let them know to chat with you.
So a variation on that, a project that I've had in my head for years, is could you reduce the incidence of residual neuromuscular blockade if on arrival to the PACU, you put somebody on a quantitative monitor? You didn't ask for anything else. You just showed them what the residual was. Would you decrease residual neuromuscular blockade in practice just by showing people what the residual was in PACU? Simple, easy, single location.
Yeah.
You guys paralyze bigger patients. I can't do it over children's businesses. Only cardiac people are paralyzed. Anyway, something to think about. Quick, easy, doable.
Yeah, so you really want to just keep narrowing your funnel to get the project to be able to be doable within your pretty short amount of time, even though we'll keep doing reiterations of the PDSAs.
But rather than something really vague like PACU workflow, just some sort of awareness of the quantitative neuromuscular blockade monitoring. And you guys don't have the size issues, variability that we have, so it would be much more doable over here. So that's a project I've had in my head for 2 years.
I'll send them your way too. John, you're here. So minimizing narcotic discrepancies in the OR, that is a passion project of a lot of residents. And you guys already have buy-in from Clark.
Yep, so I was talking with Clark, and so, I think residents, attendings probably too, and pharmacy, that we're all really frustrated with the narcotic discrepancies that, we keep getting. So we're gonna try to look at when they're occurring, when the narcotic discrepancies are occurring, and then maybe which narcotic is having the most frequency of occurrence as well. So it could be something as simple as changing what narcotics come in a bag. Maybe we would take out one Versed and add a ketamine or something like that. Or we could potentially, it'll all depend on what we find as where it's occurring most frequently and which drug it's occurring most frequently with. And then we can start working out how we would solve it there.
That's great. Yeah.
So they have some room with CA2s and potentially CA1s as well. And then, let's see, Kim, you want to talk about your standardized timeout for OB procedures?
Sure. We had a particular patient in which incited this project. Inspired. Sure, yes, inspired. Yes. Sure.
Inspiring.
Either way.
Seriously.
Anyway, basically there was a lot of yelling, social issues, etc., that led up to this mistake that we made. We were on a different floor. We were out of our comfort zone, didn't have the same nurses that we usually have. So lots of things that led to us having an adverse event with a epidural that we performed. So we're just looking at a way to work with the 4th and 5th floors of OB and mom and baby unit to have a standardized timeout that's required, like a physical handout to be performed every single time. So that way the exact same things are checked every time. So you avoid, doing a neuraxial on someone with BID Lovenox.
For example.
Hypothetically.
I will tell you, with something like that, with a checklist or a handover checklist or whatever, we can look through our past event reports. We've switched systems, as you guys know. So it may be hard for us to go too far back, but we've had a few errors related in epidurals that would address all of those issues.
Right.
So
Especially
remember the epi?
Between July and September, Gabby just presented this, there were 4 issues with anticoagulation and regional.
Yeah.
July to September. So even though
Burning platforms tire us out, you have one.
Yes, and this could eventually go over to APS too, to just make sure that's the exact same.
Start little, small team,
timeout,
see what
right.
works, adapt it.
And the OB nurses are great to work with because they get super excited about QI projects with us. So you get lots of good stakeholders.
Nurses require QI projects to advance, so they need to do these. So they will be super excited if you reach out to them and they're about to be promoted or whatever that.
Level up.
Level up. I knew there was a different word that wasn't promoted.
That's hilarious.
I think it's called leveling up. I think.
That's hilarious.
I mean, they call it probably because they still have the same job after they're leveled up.
So central line handling, we do not have a leader for yet. Sam Gilliland, who's one of the attendings, has proposed this project mainly because between he and Jason Brainerd, they've had up-teen central line issues between the ICU and the OR, either between retained wires or not suturing lines in, or you are frowning like it's never happened, but it's happened 3 times in the last 3 months.
He who frowns will have it happen next. That is the rule.
And so they would like,
just wait.
this is very much like an attending driven, we really want this passion project to happen. So far we've had 2 CA1s convinced to maybe start spearheading it. And worst case scenario, you guys will get a quick crash with a lot of attending help. So, but if anyone else wants to help with that, there's a lot of different directions this can go.
I'm just trying to really pare these things down. So knowledge of hospital policies about central line handling before and after, a little educational module, And then you can also look at practices and drop. Simple, distilled, done. The physicians never get this training, obviously. Like, you just sort of watch other people handle it with their bare hands. You're like, well, I guess that must be fine. So anyway, so this is an easy thing that kind of gets you some good capital
Traction
with the hospital.
And it has hospital support as well.
And we're trying to do the same project over at Children, so that's one of the.
There you go. Improving teaching of airway management. So as you guys, I'm sure already know, we have a bazillion learners that all want to learn how to put a tube in the right place. And we don't have a standardized process for that at all. This was a suggestion by, I think, the QI leadership team. You're
It may have been me.
this
We're doing that at We're working on that at Children's.
Someone else.
could have been. Regardless, lots of attending as well, interest. We would still need some CA3s if you guys have any interest. I have some I can just assign. And
They were here, they got volunteered.
well, or they didn't respond to an email. Handoffs, no one's volunteered for that. We do it every year. Skip it. Here's Central Line again. Proning protocols. We have the lovely Brooke who has volunteered all by her lonesome. This is again Sam's realization that we do not have a protocol in place for the entire hospital for patients we prone. And those of you that have been in our CT ICU as well as our STICU, and I think even the burn ICU, they occasionally will prone the patients for ventilatory reasons. And the fact that there is not a protocol in place makes all the nurses scared and all the attending scared and everyone else. So this has a huge ability to impact big hospital policy. You will pick one little bitty portion of one ICU to trial things in and build it up from there, but lots of possibilities there. And a lot of, again, attending support and
That
excitement
would be
from
a
the hospital.
good, easy one to partner with a nurse that's on that unit that has to level up.
So many, I'm like such a great fun leader.
Dynamic.
This one had no volunteers, so we're going to scratch it. Entitle CO2 in the PACU. Not that
People have been working
exciting.
on trying to get that in
I
place
know,
for
but it's
so
just
long
not
now.
very sexy.
It's like,
The IV securement methodology. We don't have anyone from that team. They don't want anyone else on their team. They want to be all by their lonesome, and we're going to see what happens. We'll see what happens. They have a lot of excitement about it, and they want to tackle it on their own. And then the lovely Dr. Morrissey, as Gina was telling you guys about, he was a resident here. He's over at Children's now. He really is a great teacher and really fun person to work with. He wants to do projects with either ketorolac dosing, which I think, isn't Krimstrup also working on that? Or regional timeouts. So we had two sort of volunteers. You're welcome to change your mind now that you have more information on it. The Toradol dosing is somewhat already underway from what I understand, and they're just trying to figure out, is there a per kilo max dose or min dose that gets you the max effect from what I was reading. And then
apparently you get the same analgesia, very small doses. I don't know. We don't give it cardiac, so I don't know that, but that's what I'm told.
yes.
I have to
And
look
this,
a lot of stuff up, as you guys can tell.
and then the regional
talk to mommy, I
timeouts,
have to look
they
up the
don't have
block.
theirs protocolized. So you know how our nurses don't let us put a needle in someone until we do a timeout? I guess over at Children's for their regional blocks, they don't have nurses that are that mean, which is, actually the nurses are.
Oh, no,
I
the
think they
babies,
help.
the people are asleep and still.
Oh, and nobody's doing
cooperative.
timeouts?
No, we do a surgical timeout for the case, but we don't
Not
do
the
a
block
specific block timeout.
So
Got it.
there's actually like a pop-up that shows up every time that everybody ignores.
Yeah.
Yeah. It has
So
like
sounds like,
It's like a hard
max
stop in there.
doses for every local anesthetic that you could use for a typical block that's been ordered and people still don't do it.
Can you get Epic to say your name? Like, Gina, give me time out.
don't do it yet.
So
Okay.
you guys know Scott Stenquist? You guys ever work with him?
Who?
Scott Stenquist. He's one of the cardiac guys on my team, but he's a big kind of grumbly guy. He's real he's one of the best anesthesiologists you'll ever meet. I mean, but he moves so slow. You're like, you don't know how he's that good, but he is. But anyway, when we implemented codonics, I told him that the codonics, because you kind of badge into it, I told him the codonics then knew his name and it was going to talk to him during the case. Oh, he was so pissed off. So anyway, that's where I got the idea. To have Epic talk to you. Hey, Gina.
Can it be in that voice? The best. Yeah.
So realize that this is the first year that we've let you guys kind of pick your projects and your groups and have this much leeway. Melanie and I don't think it's going to work, to be perfectly honest. And part of the reason we're worried about it is because all the groups are different sizes. They all have different numbers of people and different levels of expertise amongst them. Usually we know who gets stuff done a little bit amongst you guys and who doesn't, and we space out the doers. But you guys are going to trial this.
These people are all like, am I a doer? I don't know. Or even
We'll all
better,
find
do
out.
they know I'm not a doer?
We do. And so what we would love to have happen is that this is a flaming success and that everyone loves it, because we want you guys to work with your friends and be excited about the projects that you're doing. And the other thing, because I've realized it for 9 years, but no one reads my emails. So the other things that have changed this year are your attendings are no longer assigned to a group. So you will not have a faculty mentor that is assigned to your group, mainly because we found out that it gave you guys pretty conflicting information and didn't necessarily help as much as we'd like them to, and whatever else. So rather than continuing to torture faculty and you guys, we are going to level the playing field so that everyone has access to the same attendings. So everyone that is doing a project, we will all be well versed. So it's Melanie, myself, Gina, Tyler, Sam, and Sam Gilland. Those are your faculty. And we will be kind of your touchstones throughout. We'll be the ones saying, where are you on your project? We have a few more deadlines this year because we did learn from last year that groups waited until like the day before to put stuff together. And then they were stressed out and hating each other. And we don't want that. So the last thing, as your wellness director, the last thing I want is for you guys to not like each other at the end of these projects. So we're going to try to level that out too.
Where they live in the bubble and all the kids kill each other for food? Is that how that goes? I mean, that's like, we're sort of doing that.
No, they're fighting for forks.
Oh, yeah, I think that they eat each other. No, they don't eat each other. No,
Yeah, that's where my mind went there too.
No, they kill each other
For food. Yeah.
Piggy and all those.
So the first step is to develop some proficiency with either hospital process or policy and what the literature is, and come up with metrics. So can we say end of November?
No. This is already, no.
Oh, you
We
got
already
that?
have timelines all done. Don't worry.
Who's going to be Katniss Everdeen? That's what I really want to know.
So, Melanie did an amazing job setting up an online tutorial system for you guys, because
not really
also it somewhat is, but everything's in one spot. So we used to just send you guys emails, which people lose or erase, and now you're going to have access. You have access to Canvas. Who's not heard of Canvas? Anyone?
Yeah, heard, use.
Well, now you're all members. We signed you up.
So here's how you get to Canvas. I think you guys have done. God, I can't use your computer.
Do you want to go on that one?
So Passport, you guys have gone to the Passport site? Yes?
Yeah.
Okay. And then, oh no. So log in.
Yeah, so then you have to log in with your university credentials. So the same as your, so the same as your emails and Epic and everything else. And it'll change when your password changes. So you can do it that way.
Okay, so then you get this, right? So you can choose from an assortment of things.
This is your phone.
And so we'll pick Canvas. And then you'll have a dashboard.
That's new.
That was not on my dashboard earlier today.
You're being challenged.
Yeah, I put you on there too.
Oh, that's new. So QI anesthesia. And then different classes are different, but we just put everything under assignments. So that's where the dump is. So everything's here. I don't know, this is a new thing this year. We can use module format. We can use a lot of different things, but it's really not that that challenging. So the syllabus is the first thing. And, we're still trialing having a handbook / workbook this year. I don't know if it's the right thing or the wrong thing. Because we'll also.
PDSA cycles on you guys.
Yeah, basically. Because
PDSA RAM.
they have some great resources on the IHI website that we're going to send you to.
That giant if you want.
And I'm not sure we really need to do this anymore, but here we are. So it's similar to last year's, except you might never have read it in the past. Also possible. Here we go. So the first part is really just syllabus stuff, goals, skills, our SMART aim. We treat this a little like a QI project, right? We're trying to do similar things to what we're telling you to do. How many of you know what CLEAR is? Like it's a clinical learning experience, and I forget what the R stands for. GME assesses every site that has training programs for how well they're meeting certain expectations, and 2 of those are patient safety and quality improvement. So they come here every few years and look at the hospital system and how well that supports your training in certain areas. So it's not looking at anesthesia, and it's not looking at medicine, it's looking at UC Health. It's looking at Anschutz. So we just kind of wanted to see kind of how what we're doing with you guys fits into the CLEAR expectations for the facility, truly. So that's in here, and then some of your milestones, right, that you guys have to meet as part of anesthesia residency and how this fits into that. So when we put this together, we're thinking of a big picture, right? We want to make sure we're kind of ticking off different boxes that, we're expected to teach you. This is our timeline. I mean, it's a little rough, but it's, again, trial and error. Each year we try something different. This year we're rolling things out later than usual because we sent out what you guys want to do and what groups you want to you. It just took an additional month to get back. So whereas last year you had all this at the beginning of September, now we're mid-October. So unfortunately we're just a little more behind this year. But you're probably more nimble and agile because you have groups that you chose on projects you want to do. So hopefully you can gain a little time with that. So here's kind of, on here is kind of the expectations for when things are due, but on Canvas I'll show you where it's much clearer. And then we'll go through this IHI modules to complete. Gina alluded to IHI, it's Institute for Healthcare Improvement. Everyone that's in an ACGME program has access to IHI and all their educational materials. So we don't need to make things up to teach you didactics. It already exists, and it's very high quality teaching. So we'll send you there. We're not requiring you to do these things. This is just if you want to go through some didactic material on how to do QI and patient safety, you can. If you don't want to, then don't. But we will ask that you upload your certificates if you complete modules, just so we know kind of how well this is utilized.
And there's points this year. So remember there's book money at the end where after you're going to present your materials that you gather over the year, your whole PDSA cycle in, I think we decided May 5th. That'll be sent out to you guys. But we used to just have a panel of judges that decided which group was the winner, and those people got like $100 of book money. $100 each of book money, I think. This year, instead of it just being on the single PowerPoint, we are going to have some point systems on. Did you turn in your assignments on time? Did your group members do some of these IHI modules, those kind of things? We will prorate it based on group size, so the big groups don't automatically win. So Brooke, when you're all by your lonesome, you don't have to do all the IHI modules 6 times. But we will, that is just another piece of things that we're going to add to kind of make things a little more fair.
I was going to say something I forgot. Okay. So the rest of this is not dissimilar from last year. It's just kind of giving you some idea of what steps to take, which is what Gina actually already went through very nicely for you guys. This is just more detail oriented. But kind of just taking through each of the steps, and then your timelines on Canvas are kind of based on these steps. Again, always feel free to ask us questions about these. Because I feel this probably isn't heavily read and utilized, I really haven't had any feedback about it. I'm always open to it.
It's awesome.
There we go, we're not
Another new thing we added this year is a charter. that is derived from I was obviously going through IHI work while I was putting this together for you guys, also for my own learning. It's always nice to do some of the IHI stuff. And putting a charter together for your project makes a lot of sense. It looked like a very sensible thing to do, a nice way for you to compile where you're at and where you're going. So that's a new thing this year. And then at the end, we really just talk about how we're evaluating you. As you can well imagine, that point system that Allison alluded to is far from complete or even started. So, it will be there.
It's awesome too.
Yeah, but it's in the ether somewhere currently. Okay, what happened to the Canvas thing? Let's see. Oh,
I think
you added on this one. Oh, Firefox. Okay, so that's just to show you what the syllabus looks like. That's the very top of your assignment list, just for you to see. Then this. Oh, sorry, we have to click here. So this is going to give you the link for how to get to IHI to look at what they are using to teach people how to do quality improvement. And like I said, I think, we talked back and forth about whether we should use a workbook this year or just send you to the IHI Practicum website to take you through that. I know you don't have a... What's that? We're just giving, I'm giving you both of these to look at and kind of decide. And at the end of the year, we always are asking you for feedback about what you like and don't like, what worked and didn't work. And if you find yourself with just a little free time, feel free to glance at both of these and see what you like, and then tell us what you like to use, what you think worked better for your group. We're pretty flexible.
If you hate the IHI stuff, you can blame some of your classmates that on their evaluations of last year's process said they wanted more didactics, wanted more formalized teaching on quality improvement. And it's all, you can look at each other. This came from you guys. But the other piece is realize that most of our CA3s, when they go out on job interviews, get asked about their quality improvement projects. And it has helped them land jobs, as well as have a conversation point that's not like, yeah, I know how to intubate somebody. Yes, I promise I'm a good resident. But really like, hey, here's how I'm going to get involved as hospital leadership, because that's what they want. They don't want you to just be Joe Blow anesthesiologist. And as Gina let you know, like that's that 1% that actually gets the project done. So when you can speak well on your quality project, then that means you were involved and you were getting the stuff done. So this is also thinking past residency to that elusive job where you're going to make lots of money.
Here's the dates here. You got your first submission, which is steps 1 through 5. It takes you through the literature review, which Gina kind of alluded to as well, due December 31st. The charter document is soon after. So a month later, you should have completely organized kind of where you're going to be. You don't have to wait till December 31st.
New Year's Eve.
Whatever. Anyway, I just picked the end of the month.
Don't let it be your New Year's resolution.
And then PowerPoint for presentation is just giving you a place to upload it, so you're not just emailing it to us, which is fine, but it gets lost and all kinds of other stuff. And then, as you know, again, at the end of the year, I really think last year we said you guys could either submit a project for a resident grant, a SEPS resident grant to fund your project, say, to work on for the coming year, or an APSF video. I honestly think everyone just did the APSF video, and that really makes the most sense. It's the most simple, kind of compiles what you did, helps you put it together. I don't think it was that hard. Most people just submitted their PowerPoint and narrated it. That is not that hard. So we'll also have you submit that here because it's just a nice place, a repository for everything. And then on each of these are the modules. These are listed in your syllabus, but for each lesson, you get a certificate, so then you can just upload your certificate here. And you see that we didn't just blanket Patient Safety 101 all lessons, right? I looked at these lessons and picked ones that I thought were applicable. So yes, I also had some pain to go through all these to help pick them. So, we didn't just blanket it. So, again, tell us what you think. You might find that you just love to watch them and you watch more and more and you say, well, the other lesson was better.
Pretty easy. They're like 10 or 15 minutes. Real straightforward stuff.
And they're kind of,
I think they're good. Organizes for yourself the stuff that you already really know. So
it's not too bad. I promise it's really not.
You're gonna
Um,
send us the link to this Canvas?
To Canvas, yeah.
Yeah, they did?
Canvas?
Oh, yeah.
Like getting things done book I put up
Stuff
there.
for me doesn't go to clutter.
No, it came from like an invite.
Oh, the UC Denver.
It looks
yeah.
a little sketchy, the emails, yeah. What is
Okay.
this?
Well, you're all
from
on
to
there.
invite to Canvas.
So, but we'll send you the link to Passport again.
That's a likely story. You thought her emails were a phishing scam.
Well, not the other ones, I knew what they were.
Well, here it's it's
I
passport.ucdenver.edu.
than that on board.
If I could write it, I would. Passport.ucdenver.edu.
We'll
That's
send
it.
it as a group email. Don't worry.
It's very
Yeah.
easy.
I think I've
I logged into mine and it's not showing us.
It just got published today. So
Yeah.
if you logged in before today,
Yeah.
or before like an hour and a half ago,
At 3.
then it wasn't published.
Yeah.
Sarah's a doer.
That's exactly right. You identified the doers.
The other thing we need we would like a leader from each group to kind of bubble up just as a contact, so that when we're kind of reaching out to see how things are going, we have someone to kind of reach out to. So the asterisk, I think, on the Excel sheet were the people I think have self-identified as leaders.
Mm-hmm.
So for each group, just just at some point, let us know who's going to be the leader so we can reach out to them. The other thing we're going to do this year is check in with your group in January or so to see how the team is functioning. We were real surprised at the end of last year to find just complete disarray in some groups.
Yeah.
It was awful.
We really don't want you guys to hate each other.
Yeah,
for this
that was
That
bad.
is not my goal.
Wow.
That could be a QI project next year. We'll work on that.
So we'll check in January. Like in the past, we did not give you a task list this year, but we really want to know that everybody's getting involved. We've had people who have hurt feelings because they're not involved, and then we have people who have hurt feelings because they have to do everything. So just
Remember, tell us not until the end.
Yeah, just some mix of that is great. So we'll check in January, make sure everyone's kind of pulling their weight and nobody's real angry. And then if there's an intervention to be had,
We'll do
Allison
it.
and Nora will do it.
Joe Vogely will do it.
Someone else.
You have to go to the meeting. So it's faster to get the stuff done and to go to the meeting.
What questions can we answer for you guys? So that's a lot of information that we have thrown at you. You will have 4 study halls to get the work done. So Tuesdays from the 3 to 5, where you usually have your set didactics. When it says QI study hall, we'll have 30 minutes or so of a little spiel. So a quick, hey, here's another little topic to teach on, similar to what Dr. Whitney did today. But other than that, the other hour and a half will be all yours to work. And the last one will be all work so that you guys can get kind of your projects done. And we really, even though we just presented all these different things that you have to do, our goal is not to stress you out because we know you have a long list of things you have to do and QI projects are probably at the bottom. And that's okay. So we really want this to not become too onerous. So we're going to give you time to do it. And Dr. Oliva really wants you to get time to do it as well. And that's what these Tuesdays are going to be for. It's hard to get groups together in the hospital. It's hard to find stakeholders when you're in the ORs all the time. So that's the time where you can send people off. The reason I worry that group of 2 is going to have an issue is because it's nice to have a bigger group. So that when you're on a hard rotation, someone else picks up the slack. Because you guys do know you have those rotations where you're working that 80 hours and you have no time to breathe, let alone go do, interview a stakeholder. So spreading out that work and making everyone accountable is for your own benefit. Questions?
They look super psyched.
They look so sad. Their faces all kept dropping as we kept talking.
Still have money to go out like we did last time?
So, because no one got along last year, you now have your mentorship groups that are separate from your QI groups.
Okay.
And so your mentorship groups have money.
Okay.
Your QI, your QI groups.
That sounds like some interesting.
Sounds like a personal problem for Nate. Kick people out.
Just to piggyback on that, none of the CA1s came to the meet and greet to meet the chief candidates, so good luck voting for people you don't know.
We had a
Not that she
lovely
said
round of
something.
appetizers.
Not one.
Maybe we were working.
Not the one. Might have been working.
Okay, so the answer is no, because that moved over to the mentorship group.
Did we keep
But
money?
less.
Did we
I think we have less money.
It's
We'll
slightly
send an
less,
email.
but I'll put that in the email with the thing. I think you have a little bit, but not
Not as
no one
much.
used all the money you had last year. Not a
Right.
single group used all of it.
Our group really tried. Really, everyone would help with it. It was great.
So the trouble we had this year was this whole kind of handing it out, and we didn't know like how many people are in each group, and what are. It's just really hard to project, and we have to submit a budget, so it's very hard to figure out what the hell is going on. But I know we submitted something and we got something. Now we have to allocate it out somehow. But we did get something, right?
Yeah, I think so.
Yeah, we did get something.
We'll send that out in the email.
Oh yeah, it'll have to be pared down based on, JD and Matt don't get $500.
Brooks gets
Like
$500.
steak dinner.
She's just going to a whiskey bar and Applebee's.
Brooke's gonna be talking to herself about her QI project. She's gonna have sock puppets, I feel like.
You do have to turn in your receipts.
Yeah.
So Kathy Riggs will give you a side eye if it's all things.
She's gonna get chocolate wasted. It's
We're gonna assign Brooke some friends.
Yes.
We'll let her have some say in it, but here's your people without check marks. If you're on my list and you know you didn't see your name up there, come over. There we go. Well, considering you didn't pick a project till either.
Can I have my other Slacker sheet?
Yeah, throw me in there because I don't have to check my.
Oh yeah,
Jane's not in it. Jane wasn't on a group.
Jane would like to be in our group, and me and Diana will be the I'm gonna be gone for 2 months.
Oh, I was like, how does she know?
Uganda, and then to DC. I got the resident scholar.
Nice.
DC.
Good to you.
Yeah.
That's awesome.
I'm gonna do all my work. When do you come back? I come back in May.
So, will you be here May 5th? You will.
Yeah.
Oh my gosh.
May and June. Then I'll be back. I've described that I'm currently on the saddlebacks between the Grays and Toys. Like, I'm just like, I'm almost like got CT left, and then I'm just like, it's gonna be beautiful.
Don't worry, we'll make sure all of your vacation coverage months are in the CTAC.
Don't do that to me. My weight fluctuations.
Actually, the CTIC is the one that's safe.
I'm a little intrigued to see what.
So come up here if you do not have a group, or if you want to switch your group. They're not